You know how crucial it is in healthcare to not just do things, but to do them better, faster, safer, more effectively.
Absolutely. It's a constant push.
Well, today, we're diving headfirst into the world of performance improvement programs, or PI programs. They're really the engines driving that quest for excellence.
That's a good way to put it. The engines.
And we've got a ton of great info here, drawing from a really comprehensive guide that's updated for 2025. It pulls in the latest from CMS, the Joint Commission, IHI, AHRQ,
The
the big
It's
players.
all the key organizations setting the standards.
Exactly. So our mission today, give you a kind of shortcut, help you understand the core ideas and the practical steps for building a PI program that actually works.
We'll hit the key takeaways, maybe even some surprising bits along the way.
Think of it as your rapid onboarding, yeah?
Precisely. We've done the sifting through the guidelines, the research, to bring you the essential building blocks.
And it feels like these programs are becoming more central, right? Not just add-ons.
Oh, definitely. A key insight is seeing them less as just like quality checks and more as fundamental to daily operations and strategic goals.
Okay, let's unpack this. Where do we even start? What's the absolute foundation we need to get right for a PI program?
It really all begins with a solid structure. It's not just good intentions.
Right, need a framework.
You need a clear framework. And the IHI's 2025 insights, they really stress having an integrated approach,
Integrated, meaning,
meaning weaving technology, think EHRs, data analytics, right into your processes, and crucially, fostering collaboration across different teams.
so it's not just having the fancy tech, but
Yeah.
making it actually work with how people do their jobs.
Exactly. And this framework, it needs to clearly spell out the roles, the processes for improvement work, and who's actually accountable for what outcome.
Accountability is huge.
It is. Plus, it needs to be scalable. A small clinic's needs are different from a big hospital system's, right?
Totally different scale.
But those core principles, a well-defined structure, they apply everywhere. And a really key part is clearly defining responsibilities.
Why is that so critical?
To avoid duplication of effort, mostly. And
Yeah.
just to make sure everyone knows exactly what their role is in the whole improvement picture.
Makes total sense.
Oh,
Do we have, like, real-world examples? Does this actually make a difference?
it's absolutely. There was a 2024 study, pretty recent, showing hospitals that used structured PI programs and specifically used AI-driven analytics.
Oh.
They saw a 20% reduction in adverse events.
Wow, 20%. That's not trivial.
Not at all. It's a tangible impact directly linked to having that thought-out structure. And the interesting part,
Yeah.
the AI wasn't just flagging errors after they happened. It was smarter. It identified patterns in patient data.
So predictive almost.
Exactly. Allowing for proactive interventions. That's the real power.
Okay, that's compelling.
Yeah.
So we have the overall structure. What about the specific steps? How do you actually build an effective quality improvement program?
Right, the building blocks. AHRQ is a great guide here. They really emphasize a systematic approach.
Systematic, okay. Step one.
First, you've got to define quality, but not just generally define it specifically for your organization.
Tailor it, you mean?
Yeah. Is your main focus patient-centered care, safety, efficiency? It's probably a mix, but you need clarity on your priorities.
Because that definition drives everything else.
Exactly. It informs all your PI activities down the line.
Okay, definition nailed down. What's next?
Leadership. They have to be actively involved. And this is a shift we're seeing highlighted in the 2025 Joint Commission guidelines.
Oh, shift how?
It's moving beyond just passive leadership support. We're talking active participation in PI governance.
So not just signing off, but actually being in the room.
Right. Senior leaders on quality council agendas, driving data review, visibly championing the changes. It makes a huge difference.
I can see that. Then what?
Then establish clear accountability. You need that hierarchy for reporting, for decision-making, even how issues get escalated if something gets stuck.
Escalation pathways, yeah.
And give the program a clear name. Sounds basic, but calling it performance improvement or quality and patient safety helps solidify its identity.
So everyone's talking about the same thing. Makes sense. What about the actual improvement work itself?
Okay, so you need to identify your key functions.
Key functions.
Yeah, the critical processes that have the biggest impact. Things like patient flow, infection control, how you manage medication.
The big hitters.
Exactly. Then adopt some process improvement frameworks, Lean, Six Sigma, PDSA cycles. These give you structured ways to tackle projects.
PDSA, Plan, Do, Study, Act.
That's the one. So a team might plan a small change, do it for a bit, study the results, and then act based on what they learned. Simple but powerful.
And you mentioned information flow.
Crucial. You need to map out how data actually moves through the organization. Who gets what information, when. Timely communication is key.
Feels like a lot of pieces to juggle. How do you keep track?
Regular reporting routines,
Oh.
dashboards, reports, they create transparency and let you monitor progress.
Data visibility.
Exactly. And maybe most vital, integrating quality principles into your everyday policies and procedures. It can't be separate.
It has to be how you operate.
Right. And finally, don't overlook the educational piece. Training staff on PI methods, making sure they understand data. Data literacy is increasingly important.
You mentioned predictive analytics earlier, too. That sounds cutting edge.
It is. That 2025 AHRQ report, it showed pilot programs using predictive analytics improved resource allocation by about 15%.
15%, how?
Well, what's really insightful isn't just the number, but the how. They're using machine learning algorithms to spot at-risk patients before something bad happens.
Proactive, not reactive.
That's the goal. Allows for targeted interventions. Big potential there.
Okay, structure, steps. Got it. Now, what makes a quality system truly effective? What are the hallmarks?
Well, the IHI's triple aim: improving patient experience, population health, reducing costs.
Right.
An effective system hits those. But at its heart, it's driven by passion, a real commitment.
Passion, how does that translate?
It involves the people, their engagement, the processes, how well they're designed, and the technology, how effectively you leverage it.
So it's way more than just ticking boxes on a checklist.
Oh, absolutely. Quality needs to be baked into the culture, a core value. Driven by leadership, yes, but embraced by everyone.
Culture is a key.
And your processes. They should be standardized. Consistency matters for staff and patients. And crucially, focus on outcomes. Use data to show improvement, to drive the next cycle. Measurable results.
Are there specific best practices that really help achieve this?
Definitely. Fostering a just culture is vital.
Just culture.
Yeah, where staff feel safe reporting errors or near misses without fear of blame. That's how you learn. That's how you prevent repeats.
Makes sense. People need to feel safe speaking up.
Exactly. And leveraging digital tools helps immensely. Think quality dashboards integrated right into the EHR.
So the data's right there.
Right there. Real-time tracking of key metrics, infection rates, whatever, potentially even triggering alerts within the patient chart makes monitoring much easier.
Okay, this sounds good, but let's be real. What are the roadblocks? What challenges do organizations hit when they try to do this?
That's a super important question. Understanding barriers is step one to overcoming them. And recent research, like in AnyJam Catalyst, really highlights psychological safety.
Psychological safety again. So feeling safe to speak up.
It's more than just having a suggestion box. It's creating an environment where people genuinely trust that their input is valued, that suggesting changes or pointing out problems won't backfire on them. If that's missing, PI stalls.
So it goes beyond just policies.
Way beyond. You have to look hard at your organizational culture. Is leadership really committed, or is it just lip service?
How do staff feel? Empowered, trusted.
Do they feel trusted to make decisions,
Yeah.
to share information? And how ready is the organization culturally to actually change?
Change your heart.
It is. You also have to look at power dynamics. Are there hidden turf wars? Resistance to sharing control or resources?
Office politics.
Basically, yeah. And how well do different leadership levels actually collaborate? Is there tension between admin and medical staff, for instance?
And resources matter too, I assume.
Absolutely. Do you have the right IT systems, the budget for training, access to data? You need an honest assessment.
That is a lot to evaluate. Are there tools to help figure this stuff out?
There are. The AHRQ Hospital Survey on Patient Safety Culture is really useful. Lets you benchmark your culture.
See how you stack up?
Exactly. And sometimes old-fashioned focus groups are invaluable. They can uncover that subtle resistance or those unspoken concerns that surveys might miss.
Get the qualitative side.
Right. Those insights can be gold.
Okay, so the internal climate is critical. But what about the bigger picture? The whole organization. What other factors influence success?
Oh, tons of things. The overall organizational culture and ethics, naturally, but also, crucially, support from the governing body. The board has to be engaged.
Active board involvement.
Yes. And leadership commitment, not just at the top, but at all levels. Champions are needed everywhere. Your actual organizational structure matters too. Efficient committees, clear teams.
Structure again.
It keeps coming back. Even the scope of services you offer shapes your PI needs. And your big strategic initiatives like reducing readmissions, your PI program needs to align with those.
It sounds like everything really needs to connect.
It does. And then there are the practical things. Interoperable EHRs, good analytics platforms, can't do much without good data tools.
And money, I guess.
Yep, financial resources, dedicated budgets for staffing, training, tech. And finally, don't underestimate the political environment. Navigating stakeholders, both internal and external.
That's a really comprehensive list. I remember seeing something about the board's role being particularly impactful.
You did. A 2025 study found a direct link organizations with board-level quality committees had, I think it was 25% higher compliance with CMS quality metrics.
25% higher. Just from having a dedicated board committee.
It underscores how critical that top-level governance is. They set the tone, but they also actively oversee and drive it. It signals importance.
Okay, landscape understood. So an organization is ready, they want to launch or maybe revamp their PI efforts. Where do they even begin? What's the prep work?
It circles back to that first point, defining quality, but doing it in your specific context.
That's like.
Like, are you for-profit or nonprofit? What's your core mission, your vision? Who are your patients? What are their specific needs, demographics?
The patient population matters.
Hugely. And your service mix mostly acute care, outpatient, long-term care. What kinds of doctors and nurses and therapists do you have? Even geography plays a role, regional health issues, environmental factors.
Wow. Okay, so it's really about understanding who you are and who you serve.
Precisely. It's a very tailored definition.
Any best practices for actually doing that definition work?
Yeah, a couple of strong trends. Using patient-reported outcome measures, PROMs, is becoming much more common.
Asking patients directly what matters.
Exactly. Getting their perspective on outcomes. And reflecting CMS guidelines for 2025, incorporating social determinants of health is key.
Social determinants,
Yeah.
like housing, income.
Right. Looking beyond just clinical data to understand those broader factors impacting health equity, it gives a fuller picture of quality.
Got it. Now, let's shift to the folks at the top again. Leadership. How do they actually drive this whole PI thing day to day?
Cohesive leadership is just non-negotiable. And the Joint Commission, in their latest updates, really pushes for eliminating redundancies, streamlining leadership structures for efficiency.
Less bureaucracy.
Essentially, yes. It means active engagement from senior leaders in PI governance, like we said, a strong quality council, usually led by a senior exec or physician leader, streamlined committees, and fostering real collaboration across all leadership groups, admin, clinical, board.
So breaking down silos between leadership levels.
Absolutely. Demonstrating a unified front, a shared commitment. That's powerful.
How do they make that collaboration happen practically?
Well, technology helps. Using collaborative platforms, Teams, Slack, whatever works can facilitate communication, project tracking.
Shared spaces online.
Right. And some organizations find things like annual leadership retreats really valuable. A dedicated time to align on PI goals, strategies, build that shared vision.
Okay, you've mentioned the Quality Council several times now. Let's zoom in on that. What is it exactly? What's its job?
Think of it as the central hub, the nerve center for PI. It's the high-level group responsible for overseeing all the improvement initiatives and, crucially, making sure decisions are driven by data.
Who sits on this council?
Typically, it's a mix. You'll have administrators, key physician leaders, nurse leaders, maybe heads of important departments like pharmacy or lab, sometimes risk management.
A cross-section.
Exactly. And increasingly, patient or community representatives to bring that external perspective. Sometimes it even functions as a formal subcommittee of the board.
Giving it real authority.
Yeah.
And who leads it?
Usually chaired by a senior executive or a respected physician leader, someone appointed by top leadership who has the clout to drive change.
Makes sense. And its main functions. What does it actually do?
Primarily, data oversight. They're looking at aggregated, trended data.
Like infection rates over time, patient satisfaction scores.
Exactly. Big picture stuff, identifying patterns, spotting areas needing improvement. Importantly, though, they generally don't look at individual cases or peer review stuff.
Why not?
The focus is on system-level problems, not individual performance issues. That keeps the focus strategic. They also handle compliance, making sure members adhere to confidentiality, manage conflicts of interest, builds trust.
So system-focused, big-picture trends, how often do they meet?
Depends on the organization. Monthly or quarterly is common, enough to stay on top of things but not get bogged down.
Yeah.
And they report out through secure dashboards and reports to keep relevant people informed.
Okay, so that's the Central Council. But you mentioned other committees too.
Right. Often, you have specialized committees that support the main Quality Council. They do the deep dives into specific areas.
Like what? Give me some examples.
Sure. You might have an infection control committee, one focused on medication use or safety. A mortality and morbidity review committee, maybe a critical care committee, a dedicated patient safety committee. It depends on the organization's size and priorities.
Lots of specific expertise.
Exactly. But the key thing is coordination. These specialized groups need to report up to the Quality Council.
To avoid silos again?
Precisely, and ensure efforts align with the overall goals. Using shared data platforms helps immensely here, keeps everyone looking at the same information.
Okay, that structure makes sense. Let's talk more about that information flow. Getting the right data to the right people at the right time seems critical but hard.
It is absolutely vital. Timely decisions depend on it. And the good news is advancements in health information exchange, or HIE, are making this easier.
HIE, how does that help?
It's about improving interoperability, letting different systems talk to each other securely, sharing data between providers, between departments, even with public health agencies. HealthIT.gov has a lot on the progress here.
So how do organizations leverage that? How do they optimize their data flow?
Well, first, actually mapping it out helps. Using flowcharts to see where data comes from, where it goes, who touches it. You can spot bottlenecks that way.
Visualize the process.
Right. Then, setting clear deadlines for submitting reports is crucial for timeliness, and having clear escalation protocols.
So if data is late or something lifts off,
Everyone knows who to notify, what the next step is. It keeps things moving. And technology is a huge enabler using HIE platforms, setting up automated alerts in the EHR when key metrics go off track.
automating the checks and balances?
To some extent, yes. It frees people up to focus on the meaning of the data.
And are these tech solutions actually making a difference?
Looks like it. A 2025 study I saw reported a 30% reduction in reporting delays in hospitals using automated HIE systems.
30% faster reporting. That's substantial.
It means quicker identification of issues, quicker response, real impact on efficiency, and potentially safety.
Now, something else strikes me. With all these different committees, departments, roles, are people even using the same words? Is there value in like a common language for quality?
Oh, absolutely. Huge value. A standardized language fosters clarity. It helps align the culture. It enhances communication and engagement.
How so?
Well, think about it. If one department talks about QM, quality management, another talks about CQI, continuous quality improvement, and leadership talks about PI, it gets confusing.
Yeah, you might not even realize you're talking about the same goals.
Exactly. So organizations should consciously choose their preferred terminology, QM, CQI, PI, whatever fits best, and then use it consistently.
Consistently there?
Everywhere. In policy documents, job titles, committee names, training materials, bylaws, everywhere.
Seems like a relatively simple change, but maybe powerful.
It can be. It signals alignment. How do you implement it? You update your documents, you might rename a department or committee, and you train staff on the chosen terminology.
So everyone's literally on the same page.
That's the idea. It really helps leadership communicate goals clearly and reinforces that cohesive culture where quality is a shared understanding.
Okay, structure, leadership, common language. Check.
Yeah.
Now, with limited resources, how do organizations decide where to focus their improvement efforts? You can't fix everything at once.
Right. Prioritization is key. You need to identify the most important organizational functions to target for improvement.
Important how? Most problems, biggest impact.
Both, potentially. A balanced scorecard approach is useful here. It encourages looking beyond just clinical problems or just financial costs.
Balanced scorecard. What perspectives does that include?
Typically, financial, customer, meaning the patient perspective, internal processes, and then learning and growth, like staff development.
So a holistic view. And what kinds of functions are we talking about?
Could be clinical things, pain management, infection prevention, medication safety, or operational things, patient flow through the ED, discharge planning processes, scheduling efficiency.
How do you actually choose which ones to tackle first?
It really has to be data-driven. Look at your performance data. Where are the biggest gaps? Where are the high risks, the high costs, the poor outcomes?
Let the data guide you.
Yes, and align your choices with your organization's overall strategic goals. If reducing readmissions is a top priority, then functions related to discharge planning or patient education might rise to the top.
And involve the front line.
Absolutely essential. Engage frontline staff. They know the processes intimately. They often see the problems and potential solutions that leadership might miss. Their buy-in is critical anyway.
Makes sense. Any tools besides the balanced scorecard?
Predictive analytics, like we discussed earlier, can help forecast areas where problems might arise, allowing for proactive focus. It's about using data intelligently to place your bets.
Okay, last big area. It feels like hospitals and clinics aren't islands. Is there value in looking outwards, collaborating?
Huge value. Participating in external quality initiatives and collaboratives can seriously amplify your PI impact.
How so?
You're leveraging shared knowledge, shared resources. You're not reinventing the wheel. Think about national collaboratives run by IHI or CMS.
They bring lots of organizations together on a specific problem.
Exactly. Or local partnerships, maybe working with other providers in your region, even just joining professional organizations focused on quality. And don't forget internal initiatives too. Sharing successes and learnings across departments within your own organization is a form of collaboration.
What are the main benefits of joining those bigger external efforts?
You get access to proven best practices, you get benchmarking data, see how you compare. That can be really motivating, or identify areas you hadn't considered.
Learn from the best.
Pretty much. It also boosts your credibility with regulators, payers, even patients. Shows you're committed to continuous learning and improvement.
Any examples of that working well?
Sure. A 2025 IHI report highlighted hospitals participating in national sepsis collaboratives. By adopting shared protocols and evidence-based bundles of care,
Yeah.
they saw significant reductions in sepsis mortality rates. Real lives saved through collaboration and shared learning.
That's powerful stuff. Wow. This has been an incredibly thorough deep dive into performance improvement.
It covers a lot of ground.
It really does.
Yeah.
It's so clear that building an effective PI program isn't just one thing. It's this complex interplay of structure, leadership, culture, data, everything working together.
Exactly. It demands that continuous commitment,
Right.
a willingness to look at the data, learn, adapt, and a truly collaborative spirit top to bottom. That's how you build and sustain a real culture of quality.
So as we wrap up, here's something maybe for you, our listener, to think about. Consider how these principles, continuous improvement, data-driven decisions, collaboration, might apply beyond healthcare.
Interesting thought.
Right. Think about your own work, whatever field you're in, or even personal goals. What if we all approach things with that same focused improvement mindset? What could that unlock?
What new heights could we reach?
Exactly. Something to mull over.